Thank you very much, Chris. Folks up the back, if you want to, feel free to come and mingle in and find seats and that sort of thing. I won't be at all offended if you're passing by. Thank you very much for having me. We're going to just talk a little bit about the strategy and what's been the process of developing the strategy, I guess. But I know that the expectation of the strategy is that it's that. We do everything, everywhere, all at once. We probably won't quite get to that, but we're making some strong attempts to try and get things sorted out. Thank you, Chris, for the acknowledgement, and I'd like to acknowledge the traditional owners of the land as well, and people with living experience, and thank Uncle Tony for his generous welcome yesterday. I'd also like to acknowledge all my patients who I've had for 25 years now, who've taught me a great deal, and to acknowledge my proud Aboriginal daughters and grandkids who've taught me the meaning of resilience. So I've been appointed the Chief Addiction Medicine Advisor. I'm going to talk about that in a minute. It's been a role that's been called for quite some time. One of the proudest moments I've had an opportunity to talk to lots of people doing this in this new job. And I was very pleased you can see there my various qualifications. And the third line of qualification is perhaps one I'm most proud of. Kate from Your Community Health told me about this, that she was speaking to somebody and talking about the Chief Addiction Medicine Advisor role, and said that Paul's been appointed into this role. And the other person said, "Oh, he's not a dickhead." So I'm hopeful. You'll see there's an asterisk there. Because for the research types among you, you know this is an N of 1. So it's not really significant yet. I'm hopeful that during my time that I've got to do this role, that I'll, at the end of it, maybe I'll be able to maintain that qualification. So the Chief Addiction Medicine Advisor role is based in Safer Care Victoria. So Safer Care Victoria has been an organisation set up really to look after health services, so mainly hospitals and that sort of thing. So it's part of the challenge of the role is to work out how Safer Care Victoria might be able to interact with the AOD system, the AOD sector. That's something we'll be working on as we go. As Chris said, it's been called for in the Orion report, VAADA's been calling for it, and somebody with a proper award after their name also has been calling for it for a while. So the scope was interesting to try and work out. So potentially a Chief Addiction Medicine Advisor role could potentially advise, around the 30 addiction medicine specialists that exist in Victoria. But I've been really honoured by the generous acceptance of the role to speak to both addiction medicine, but to the wider AOD sector. So I've been very grateful for the support that's come from everybody really here for being able to do this role and to speak as a bit of a connection between the sector and the department, and to try and join up some of what's quite a disparate kind of sector really. And I'll talk about that in a second. So part of the role is to give clinical advice and direction to the government, to chair the Ministerial Advisory Committee that's being put together at the moment, and to give some advice on strategy. So I've spent a bit of time speaking to Stefan lately, and Stefan, if you don't mind me suggesting that the role is something of a bridge, as I was talking about, between the sector and government, between hospitals and the sector, between research and non-clinical research and clinical research. So there's a real opportunity to try and connect everybody up, and that's something that I'd really like to be able to do. So a 10-year strategy. I don't know about you, but if you doom scroll like me every morning, 10 years seems an awfully long time. Who knows what the world will be like by that stage? But it is a really great opportunity. That's the theme of today. My wife, when she learned that I got this job and that one of the significant roles was to provide advice to the strategy, she laughed heartily. It was equivalent to me being appointed the IT manager for Victoria, she thought. Strategy is not my thing. My job for 25 years has been to work in general practice, basically. So I see whoever walks in the door. The most strategic I've been is working out where we're going to go for lunch at Inner Space, my mates at Inner Space. So strategy is not quite my thing. In fact, I'm a bit of a strategy agnostic. I believe they exist. I'm just not sure how much they affect things. So it's rather than just, oh, I'm missing a slide, but there we go. Rather than sook about it and complain about it, I decided that because what I was unsure about was how will the strategy help things, for example, how will it help people being released from prison to be able to find a prescriber? These problems that we face, the questions that we have, a person with cirrhosis still drinking heavily, been in and out of rehab, families that don't know where to turn for a loved one using ice and they're paranoid, terrified, people attending mental health locals looking for drug help, getting naltrexone, organisations being able to know that they can provide ongoing support and care for people, reducing the risk of harmful use, prevention, nitazines. But so rather than sook about it, I've really been able to see by working with people that there's the great opportunity that exists with the development of a strategy. And part of that opportunity is to connect. And so an event like this, I mean, this is an amazing event, I think. I was reflecting last night to have as many delegates as turned up yesterday and today for a Victorian conference from a relatively small sector is amazing. And it's a credit to the sector for its unity. And the strategy is an opportunity to continue that. So for us to connect up, to think big, to think about new ideas, new ways of doing things. So that's something that I'm very interested in. You know, how do we move from doing things that we've just been doing, just because we have, it's the way things have evolved, to finding ways to do things better. That can involve some marginal sort of direction change, or it can involve some wholesale reconstruction. So that's something that one of the opportunities the strategy offers. It's an opportunity to complain. There's been a bit of that, and that's okay too. It's normal because we're working hard. Things don't always go the way we'd like. There's never quite enough money. But there's an opportunity to be hopeful, to be inspired, and to continue to work together. So the first question we're asking really is, what is the AOD system? Is it a system at all? I've had a number of conversations with Susie, who would question whether we've had a system in any sense. You know, when we've got a scenario where people might turn up in an ED, they might get an assessment by an addiction medicine specialist, but then not be able to access a detox for another 3 months because they've got to wait to get a comprehensive assessment, all these sort of things. So that's not a system that's working well, just as a simple example. It's a bit complicated. Who's in the AOD system? Again, as I was reflecting on it, I've been doing addiction medicine type work in GP, in general practice, for a long time, but I'm not really part of the AOD system. So reflecting on what is the AOD system? Does addiction medicine fit in, the doctors in hospitals? Do private rehabs fit in? Do the ED hubs fit into the system? How does it all work? How does it all fit together? That's all the questions we were starting to ask ourselves. Why do we exist? What's the purpose of the AOD system? Is it something that could be done by someone else? Why do we get up in the morning? What's our purpose in our work? There's a number of a list of things here, of the things that happen within the AOD system. What is the point of it? I know things like advocacy, and again I'm talking about addiction medicine because that's been some of my experience. But I know that is it part of the AOD system for an addiction medicine team to advocate for a person in hospital who's come in with a severe burn and who's on methadone and has been offered some anti-inflammatory for their severe burn on their arm? I would say that it is. But it's not really included in the AOD system as we think about it today. There's a whole lot of things that we do as part of that. Thinking about what will people's experience of the AOD system be like in 5 years? What do we want it to be like? What are we hoping that people will, how will people approach it? How easy will it be to access? How effective will it be? Will we be able to manage stigma? Is it part of our role to try and deal with stigma that presents throughout other aspects of our society? So potentially a good system. These are sort of some of my thoughts really about what might make up a good system. So one that's well funded, allowing for long-term planning, not just sort of short-term band-aid measures. Being able to identify those people who are most at risk and putting our attention specifically to those. I remember with my foster daughters, who I mentioned earlier, many years ago, them sitting in a house. Their mother was using a number of substances and quite chaotically, and we were visiting them in their home, and the house was full of smoke up the level that I was living, where the kids were. It wasn't too bad. There was drug paraphernalia around the place. The kids were living effectively by themselves. Their mum was out and about. But the drug offensive book was on the table. The government had produced the National Drug Offensive. I don't know if you remember that. As though that was a solution for this family. So, that's that kind of overarching campaigning. No, maybe it has some place, not the drug offensive, but maybe that sort of campaigning has a place. But we really need to be looking at who's most at risk. How do we intervene with people in that kind of scenario? So a good system is everyone working together, using the best elements of their profession. My recollection of one of the most effective periods in my career was working with Primary Care Connect in Shepparton, and Deb and Bron, I don't know if you're still around today. There you go, thanks Deb. Where I went up to Shepparton once a fortnight. We had a nurse who was there 2 days a fortnight, and I only saw people who came in to that service at Primary Care Connect. So people could walk in off the street. They knew that Primary Care Connect was a place where people could get AOD treatment. They'd walk in off the street on the day. They'd see an intake worker, have an assessment done right there, be linked up and be able to meet their case manager that day while they were right there. That week, they'd be able to be booked in to see me in the clinic. They would come in with their case worker and the nurse, see me in the clinic that day. We'd be able to get them started onto a program or started on some medication for alcohol. I was able to learn from the case manager everything that was going on in that person's life, with their permission, and everything that was going on in Shepparton. And by the third patient who came in, I didn't have to speak to the patient about almost anything. I didn't have to explain pharmacotherapy because the case manager had already done it. They'd explained about naltrexone for alcohol. That sense of working in a team, being part of a team with no hierarchy, me just being part of that engagement is something I really reflect very fondly about. And I think it's a model for what we could continue to do. Providing whole person, whole family care, being integrated, working with other areas of need, so making sure that people can get help for their homelessness and mental health issues. Being easily accessible, low barrier, and responsive to need. So my mentor when I first started in general practice was David Jacker. So he's somebody who many of you will know. And again, if I can finish my career emulating the work of David, I'd be very happy. And that's something that he taught me, that we need to have services that are easily accessible and low barrier and responsive and opportunistic. Now, I don't work in quite the same way as David. He was responsive and opportunistic at 10 o'clock at night when people called him on his phone. And he's been on call for 12 years at Monash. That's, for those of you who know David, you won't be surprised to hear that. But those kind of services are what we need, not putting barriers in front of people, bringing them down. A good system will help to reduce stigma and lead to increased connections for people back into the community. So how's it looking? Is there any fruit on the tree? I have some fruit trees. I'm fortunate enough to have some fruit trees, and I presume that this is a place from a magical country where they don't have parrots. So where have we got to? So focus areas that we're working on. So I need to declare that I can't be too specific about the strategy where we're up to at the moment. It has to be signed off. The government has to sign it off and that sort of thing. But the big issues we're focusing on: reducing deaths and other harms from alcohol and other drug use. You can understand that would be an appropriate place to start. Increasing accessibility, arranging for appropriate funding, and being efficient with what we have. It is a time where we need to be efficient, I'm afraid. There's no messing around with that. We know that the state of finances at the moment, but there's ways we may be able to find to do things. Getting better at what we do, providing the best treatments, not just what we've continued to do in the past. Knowing that what we're doing is helping, so measuring, finding ways of measuring and knowing what outcomes we're producing, and providing for the development of excellent supports for our Aboriginal people and other diverse groups in the community. So that's kind of the direction we're heading in. And for example, the case examples I mentioned, sort of things that are being developed are to improve the pathways and specialist forensic AOD services for people involved with the criminal justice system. And remember, this is a high-level part of the strategy. The implementation part comes next and is being written up as we speak about how these things are going to be delivered. And this comes from the principles of being human rights driven and equitable and recognising individual needs, so that people, even when they go into prison, deserve equal care. And looking to drive collaboration and system integration. So when a person comes out from prison, they can be connected in with a primary care provider that can continue to provide the care, and maybe even having a connection with that primary care provider while they're still in prison. So there's a warm connection there where people know what to expect and know where they can go. Reducing the risk of harmful drug use in kids. So prevention, I hope I'm always prepared to learn, and I've really enjoyed spending some time speaking to Professor Doug, who's going to speak to you very soon, and who pointed out the importance of us continuing to talk about prevention. And we're talking about treatment in all sorts of ways, treatment and harm reduction. But Professor Doug will talk about the alcohol industry and pointed out that the treatment side of things, the industry wants us to keep talking about treatment because that's marginal. It's a small number of people. Vice industries like the alcohol industry are pushing and causing harm on a huge number of people in that bell curve that we need to be, as a system, advocating to reduce the harm that whole industry does, not just providing treatment at the top end of things. And prevention starts early. I've learned as we've been going through this process that through the clinic at the Women's, Yvonne Bonomo was telling us that they've started a first 1,000 days project, which is very exciting. So looking at the importance of those first 1,000 days in a child's life, or from conception, and being able to focus and make sure that children and their families are as supported as possible during that time. That's the prevention side of things. Making sure we're ready if nitazines or something else arrive in a big way. So we're strengthening our drug surveillance system. There is a drug surveillance system, believe it or not. So there's a number of ways that it happens at the moment. It was EDNAV, which I think Jen's talking to my friend Raf Epstein on the radio at the moment. In fact, it works on EDNAV. John Fitzgerald works on RAPID, so testing residual syringes through the MCER and now in Barwon and through CoHealth, testing for what's around, what's being found, and we now have drug checking services being developed, which will provide more opportunities for surveillance and early warning. Getting naltrexone out, so we know that as part of the statewide action plan, there's going to be an increased rollout of naltrexone, and the strategy will continue to strengthen harm reduction supports that we know are effective, and focus on reducing other AOD-related harms, including fatal overdose. For families, we're looking to develop programs that are designed by people with lived and living experience, and including the families, of course. Improving access to information for people, improving service navigation, and improving integrated care capability across the system so that people are connected, so that there is a system, as I talked about before. Person with cirrhosis is something that's, having spoken at the VAADA conference, Service Providers Conference last year, that's a guide for folks. If you speak at a service providers conference, it can have an impact on your career. So person with cirrhosis still drinking. So the principles here that apply are a human rights principle. I bang on about this all the time, that people have a right to the best treatment. Recognise individual need, so providing particular treatment as people need it, not just providing a service and expecting people to adjust to the service. Being evidence-based and collaborating. And the strengthening the role of primary care providers in the system so that people have got access to things like medication for alcohol, opioid pharmacotherapy, and other treatments as they come available for other types of drug use. So we're really at the start of the process, but as a group here, if I can include myself in the we really have a great opportunity here. So it's a very hopeful time to my way of thinking, despite some of the pressures and issues that we face, with the finances and that sort of thing. I've had the privilege of working and speaking to many of you, hearing lots of things that are going on, and being encouraged by your passion and inspired by your desire to find the best way of doing things. And I think if I can quote my namesake, we'll. I thought of a few things. I thought, we can no longer let it be. We need to come together. But ultimately, I think together we can work it out. Thank you for your time.